Okay, well, good evening, everybody. My name's Ian Stansfield. I'm Director of Research in the School of Medicine, Medical Sciences and Nutrition, and it's my pleasure tonight to introduce our Cafe Med speakers. Two speakers this evening are Professor Justin Rochford, and Justin, his research area he's going to tell us more about in a moment or two, focuses on fat in the human body, where it's deposited, and how fat deposition can go wrong in certain types of clinical condition. And he's going to be joined in that discussion of all things obesity related with Dr. Shai Nanthakumaran, who is a consultant gastrointestinal surgeon working in Aberdeen Royal Infirmary with special expertise in bariatric surgery. And between them, they're going to give us an insight into everything that goes wrong when we get bigger and when we get smaller, I think, with fat deposition. So I'm going to hand over to Justin first to start the discussion. Over to you, Justin.
Thank you very much, Ian. Right, so I'm clutching a piece of fat because I have a research lab. My research lab's really interested in fat tissue, and so I want to try and convince you that fat is really interesting, despite the fact that this looks like a really uninteresting, yellowy blob of fatty stuff. So this is what I'm going to talk about, and I'm going to try and convince you possibly even that the cells that live in this lump of fat are as clever as neurons, brain cells, which everybody knows is really clever. So I'm going to put this down so I don't have to wave it around anymore, but this is what we're after. So, right, and this, which is hopefully not going to stay here long enough for me to talk about it, is an MRI scan. Many of you probably know what an MRI scan looks like already. And so what you're looking at is in white are the areas of this fat tissue which show up white on this particular type of MRI scan. So now, if people are willing to speak, or at least put their hands up, I want to ask you which you think is the least healthy individual of these three. If we say A, B, and C, who thinks that A is the least healthy? Who thinks that, I'm seeing no hands, so I'll do a show of hands. Who thinks that B is the least healthy? B, you think B, excellent, right, we've got some. And who thinks that C is the least healthy? So most people who are willing to express an opinion think that C is the least healthy individual there. So I'll come back to that. So I think you're right if you think that C is not very healthy, and that's because many people know that gaining a bit of extra weight, certainly gaining a lot of extra weight, isn't very good for us. We get various conditions associated with that. So by a show of hands, who knew before they came here today that gaining a lot of weight is, generally speaking, bad for you, right? Pretty much everyone. Everybody knows that, okay? But who, by a show of hands, knows why gaining extra fat is bad for you? I'm not going to necessarily ask you to justify that statement, but you can if you're willing to. Who knows why? Because all three of these individuals have some fat. We all have some fat. Some people are very, very healthy. So it's not bad to have the stuff. So why is it unhealthy? So I'll ask one more question, which if people are willing to give an answer to, is, do you know any conditions, any diseases which are associated with being very overweight? Diabetes, excellent. I'll talk a little bit about diabetes. Any others? Heart disease, excellent. We're going for the big ones. It was going to be heart disease. Any others? Good, any others? Okay. So, heart disease can either be the heart or also your blood vessels getting lots of fatty plaques in them, so that's really bad for you. So why would you, when you've got lots of the extra stuff, why would you get these plaques in your bloodstream? Why would you get fat why would you get diabetes? So maybe I want to tell you a little bit about why that happens, unless someone thinks they have any ideas. Because it's not intuitive, is it? I think, that's the key thing, right? So the answer is actually that despite this individual here, there's a very good chance that they might develop type 2 diabetes. They might get atherosclerosis in their blood vessels. They might get fatty liver. In fact, they have got fatty liver because you can see their liver and it's full of fat. And the reason is actually not necessarily because they've got all this fat. It's because they've filled this fat up so much that it can take no more. And so the fat, instead of carrying on being safely stored in that tissue, is now starting to go elsewhere, and that's what causes the disease. So actually you could argue that the problem if you gain too much weight is you've actually got too much. You've got too little fat. In fact, if you had even more, you'd be able to safely store the fat there. So that safe storage in this lump of fat tissue and in these cells that are showing up in white, that's being done by these cells called adipocytes. These are fat cells. And they're round cells, they pack together, they look a bit hexagonal when you pack them together tightly. And those cells are what my lab spends quite a bit of time working on because we want to understand all the things they do. Because in fact, they do lots of interesting things. Okay, so the most important thing they do is to store fat that you get in your diet, dietary fat, and that's what they should be doing. And they should be storing that and stopping it from going to all these other cells and tissues in the body. Okay, and so the reason you get diabetes, for example, you say diabetes, so one of the reasons you get diabetes is because you start to get fat accumulating in the liver and it no longer controls your blood glucose levels correctly. It stops the pancreas that normally secretes insulin from secreting insulin properly. So that's one of the reasons why gaining weight can be quite bad for you. So that's the number one thing I wanted to talk about. So you'd imagine that these cells, these fat cells in this fat tissue then is not very clever. All it's doing is storing fat. But actually they're quite remarkable. So if I told you that those cells that are sitting in that fat tissue, in that sort of lump of yellow fat, so the smallest ones, when they're not storing much fat at all, they'd be about the size of a pea. But that same cell, in theory, if it decides to store lots of fat, could be as big as an orange. I'm talking relatively speaking. If you made the cell size, they're all tiny. But in terms of the ability to get bigger, if you made the smallest ones the size of a pea, relatively speaking, the biggest they could become is about the size of an orange. So that's quite a huge change to make in the size of a single cell, so it can do this job of storing fat safely and keeping the rest of your tissues and your organs safe and stopping the fat from accumulating in those tissues and organs instead. So that's what they do. Now, the even more remarkable thing I would say about these cells that have turned from, relatively speaking, 10 times larger in size is that if you imagine the analogy of it going from being the size of a pea to the size of an orange, because as a tenfold change, that's what that would look like. If you imagine that analogy of it being an orange, actually everything that cell is going to do, it will do in what is effectively the skin, the peel of the orange. Because all of the middle of the orange, all of the juicy stuff that we'd eat, that would all just be the stored fat. So there's nothing going on there apart from storing the fat that's stored in those cells. Everything the cell is doing, and I'll tell you a couple of things about the things that those cells do, is being done just in a tiny thin film all around the outside of the cell. Does everything. So all the machinery to make it store the fat is all just in that tiny thin layer around the outside. And it manages to do that just with that really thin skin of stuff around the outside. Contains all the enzymes and all the organelles it needs to process that. So that's what these remarkable cells are doing. And they're managing to do that. So what are they doing? Well, they're storing fat. That's the most important thing they do. But they also secrete quite a few hormones. So these factors that get secreted into the bloodstream and control some quite important processes. So I'll give you one example. So there's one hormone which is called leptin, which some of you might have heard of. It's a hormone secreted by fat cells, and that hormone gets secreted into the bloodstream, and it tells your brain that you have lots of nice healthy fat stores, so you don't need, you shouldn't be voraciously hungry. And what happens is if there are some very rare individuals who don't have any of this hormone leptin, they have a mutation in the gene that codes for that hormone, and those individuals are hungrier than you have ever felt in your life all the time because they lack this hormone. So that fat tissue, which looks like a unimportant lump of fat, is actually secreting hormones that really control in your brain how hungry you're feeling. So it's quite a remarkable thing for a fat storing thing to do. And again, they're doing that from that tiny thin skin around this enormous droplet of fat that's in every single one of those cells. So that's one other thing that those cells are doing is they're secreting hormones. So leptin's a good example, but there are some others as well. Okay, so I will go back to my picture of our three individuals here. And so actually, what I can tell you is that you were almost right that this individual on the right you're right that they're unhealthy, but they're actually probably not the most unhealthy in terms of getting diabetes. The most unhealthy person here is the one on the left. And that's because that individual has a condition where they're unable to develop fat tissue, they're unable to make fat cells. So that's why you see almost no white at all, is because they just cannot make fat. And the problem that happens in those individuals is that because they can't store almost any fat at all safely from birth, they get very severe forms of diabetes from a very early age. They get several other, significant problems. They get lots of joint pain, for example, because you have fat within your joints that help cushion the joints. So fat's doing lots of different important roles. So those individuals with no fat at all actually have very fatty livers. Their livers of those patients accumulate lots of fat because they can't store it anywhere else, and they get a very severe form of diabetes. So we're really interested, the reason I'm telling you all this, we're really interested in finding new treatments for these patients, because actually they're very difficult to find good treatments for, because all the things that you develop to treat diabetes are often trying to help these people. So you can try and help these people by trying to find ways to lose weight or become more sensitive to the actions of insulin, or you can give them more insulin so that to help try and treat their type 2 diabetes, certainly. But many of those things just don't work terribly well in these patients, and so that's why we're really interested in what fat cells do and how we can find treatments that work for people who have fat tissue which doesn't work properly. Now, I'll just make one other point, which is that there is one treatment which works for these patients, but it's actually the second most expensive, or certainly was until recently, the second most expensive drug on the market in the US. It's a fantastically expensive drug. It's not widely available, or it's becoming more widely available now. And it's actually the sort of the manufactured form of that hormone leptin that I told you about, that controls how hungry you are coming from the fat tissue. And actually what we know is that if you can give that hormone back to those individuals, because they don't have any, because they've got no fat tissue, it actually makes a big difference. It really helps their diabetes, helps reduce the amount of fat accumulating in their livers, and it really helps their diabetes. So it just shows you that if you can modify hormones coming from fat tissue, that can be a therapy. But we're trying to find new things which might do some of those same jobs. Now, I'm trying to keep an eye on the time. I want to tell you two more things about fat, which I think you wouldn't necessarily think. So I've shown you this nice lump of fat here, and you think, well, that's what it looks like, and this stuff here, that's going to be the same as this stuff here, and this stuff here. And actually what we know is that that's not true. So we know that here on the thighs and on your buttocks, that's actually quite a healthy place to accumulate fat tissue. I'd argue it may well be that we developed that that's where we should have fat, is under the skin, particularly in the lower body. And that fat, for some reason, if you accumulate quite a bit of that fat, it's quite healthy, in fact. It's doing lots of good things, it secretes lots of good hormones, and it stores fat very well. What's less good is if you start to accumulate fat under the skin in the upper body, then that's less good for you. And if you start to accumulate fat tissue around your organs, that's really bad for you. And actually, after you've started to accumulate fat around your organs, that's particularly when you start to get this fat accumulating inside the liver as well. So what we know is that these different, what we call different fat depots, these different types of fat around the body, actually they're not all the same. So they look the same, but they're not the same. Some of them are healthier than others, and so that's why having a different distribution of fat in your body can make a difference to how healthy you are, your risk of diabetes or your risk of heart disease. So, and so what we're really interested in as well is trying to understand, well, what's different about that? Because if we know this fat's healthy and this fat's unhealthy, then could we try and make more of your fat be like this fat? And therefore that would be, would sort of reduce your risk of diabetes and reduce your risk of cardiovascular disease. So that's another aspect that we're really interested in. And so we know those different fat that's accumulating in different parts of the body is different. But what we also now know is that even within any individual fat depot, individual piece of fat, there are actually multiple different types of fat cells. These are adipocytes. They all look identical, but actually if we work out exactly what genes are being expressed, exactly what hormones they're secreting, they actually might all look the same. But this is my analogy with neurons, with brain cells. Actually, they look very similar, but they're doing slightly different things. And so what we also know now is that probably if you could just, even within one different region of fat, you could make you have more of the healthier cells and less of the unhealthy cells, then that could really make a difference to your risk of diabetes and your risk of all these diseases. So that's another thing we're really interested in, is trying to work out how these cells differ and whether we could change their functions to make them more of the healthy type. Now, I'll, I think, finish with a piece of good news, which is quite often you look at these things and say, oh, well, you know, people gain weight, and then, you know, it's really, particularly so, it's really difficult to shift fat from your sort of lower body, and that's a really bad thing, and also that, you know, it's really bad about gaining weight, and it's really hard to lose weight. But so I just want to finish with what I always think of as a kind of positive thing, that if you do try and lose weight, if you've got diabetes or you've got a higher risk of any kind of conditions associated with obesity, the good news is that the first thing that happens when you start losing weight is you lose it from the worst places first. So that's why if you lose a little bit of weight, you often get a disproportionate benefit to your health. Your risk of diabetes will go, or if you have diabetes, your diabetes will get a bit better, more than you would think for a given amount of fat loss. And that's because you tend to, first of all, you'll start to clear the stuff out of the liver, which is doing you proper harm, but also you'll tend to lose this upper body fat first before you lose the lower body fat. And that's why it's often said it's difficult to shift fat off your hips. My argument is I suspect that's because you're getting rid of the stuff you really shouldn't have first, and you get left with the stuff that's actually not so bad for you. So I think I've hit my time, and I'm going to hand over to Shai, and he'll tell you some more about what he's been doing. Thank you.
Thank you very much, Justin. Can I, Justin, I'm going to take your picture down if that's okay, if you don't mind.
Get that out of the way.
And I need to find a pen. Fabulous. So Justin's very eloquently explained to us about obesity and that visceral fat, that central obesity, and how it impacts on our health, and it lends itself to something called metabolic syndrome. So as a surgeon, what we try and do is we're trying to work out how can we help patients, how can we support patients by getting their weight down and reducing that visceral obesity. So the first thing you probably say is, why can't we just diet? So if we put on weight and we develop obesity, why can't we just diet? And a number of patients who I'll see who come for weight loss surgery will be able to diet and will be able to sustain a degree of weight loss for a period of time. But it's really difficult to sustain that long term. So they can do it for about 4 months, and then they struggle. And the reason for that is our bodies are set and our appetite's set at this level. And when we lose weight, our bodies are telling us that we're in a period of starvation. And so we're constantly feeling hungry, and then your weight shoots up and you put on a bit more weight. And then you get this classical yo-yoing effect, and you just gradually continue to increase weight. So back in the late 90s, in Sweden, they did this fabulous study, and it's a seminal study that was performed. And what they did is they took 4,000 people, and in 2,000 people who were obese, they performed weight loss surgery. And in the other 2,000 patients, what they did was they subjected them to dietary interventions, physiotherapy, psychology input. And what they saw at the end of that study was that those who didn't have surgery were able to lose weight in that short period, in that first 6 months, but unfortunately they put that weight back on. But in those who had surgery, at 1 year, they lost about 30% of their total body weight. So quite marked weight loss in that first year. But the key to this is not only are they losing weight, their health is improved. And as Justin's explained, their diabetes got better. And they were less likely to develop heart disease and stroke. And in female patients, they were less likely to get cancer. So not only did they lose weight, there was quite marked health benefits from this that was picked up on this study. And as a result, patients who had surgery were more likely to live longer. So this was the first study that actually said, do you know what, there's great evidence to show that weight loss surgery can be used in a treatment algorithm to help patients with obesity. But as a surgeon working across the way there, I'm just a tiny part of the team. And it's really important when patients come to us that we have to have this kind of holistic approach to how we manage them. So it's really important that when they come and seek support from us, that they're entered into a structured weight management program. So let's try dietary interventions initially. And if they've engaged but they haven't quite achieved their targets, then the question is weight loss surgery. Is this the right thing for them? So all patients that we operate on will see a psychologist, because we know that when it comes to eating, we all comfort eat. And a lot of our eating behavior stems from a number of psychological things that have happened to us in the past. So it's really important we address that and tease out these issues, and that they're managed before we subject them to an intervention. So they all see a psychologist, they'll all meet up with a dietitian, they'll go through a structured weight management program, and we talk to them about types of food groups, we talk to them about carbohydrates, proteins, fats, we talk about exercising, we talk about that psychology, what drives our appetite. And once they've been through that structured weight management program and they're still keen to engage in weight loss surgery, then we will assess them and talk about, what might be the right operation for them. So it's quite a pathway to go through. Currently, the two most common operations that are performed worldwide are something called the sleeve gastrectomy and the gastric bypass. So it's important, if we're going to do quite a radical intervention to a patient, it needs to be a safe intervention. Patients need to recover quickly, and then they can get home out of hospital and convalesce. So it's really important when we do these operations that we do them keyhole, so small cuts in the stomach. So we probably 5 small cuts, about 1 centimetre or so. The operation usually takes about an hour or 2 to do. And if everything goes perfectly well, they're usually home after a day or 2. So the complication rates from these types of operations are actually quite low, as long as you ensure that you work up your patients appropriately. So I'm going to try and draw you some pictures. And when I first started this, and I was speaking to a colleague, and I hadn't appreciated, we've been doing weight loss surgery in this part of the country, so the north of Scotland, for 50 years. And it was one of my mentors, Jack Miller, who first started doing surgery in Elgin back in the 80s. So he'd gone across America, learned about surgery, and came back. And my other colleague, Duff Bruce, started doing keyhole weight loss surgery 2003. So this has been going on for a period of time. But and when we first did these operations, we thought it was all about restriction. So we would make the stomach smaller. You can't eat as much. But it's not. It's much more complex than that. Now I'm going to try and draw some pictures. So bear with me, please. So here we are. Here's your stomach. Here's your gullet. There's your mouth. There's your gullet, and there's your stomach. And if this is your abdomen, what we'll do is, so this is keyhole surgery. So there's your belly button, and usually we have 1, 2, 3, 4, 5 cuts. And this retracts the liver out of the way. This is our camera, so we can see what's happening. And these will be the surgeons, or my instruments, and this will be the assistant's instrument. And what we'll do is, as I say, there are two types of operations, the sleeve or the gastric bypass. So I'll talk about the sleeve gastrectomy. It's probably the most common operation done worldwide. It's probably done in about 70% of patients having weight loss surgery will have a sleeve. And what we do is we mobilize the stomach and we divide all the blood vessels with a special energy device. And then we take this stapler and we go up and divide the stomach and we get rid of all of this. And so what we do is we pull this out through one of these ports and extract it. So you're left with this little cylinder of stomach. So you can see why you're restricted. So you can't eat as much. But it's just not restriction. And it's all about these fancy hormones that are secreted. And here, what this bit of fundus, what it produces a hormone called ghrelin. And ghrelin makes you hungry. So by taking this bit of stomach away, not only are they restricted in what they eat, they don't feel as hungry. So I see patients coming back to clinic and they just tell me, do you know what? It's such a strange feeling. Whenever I dieted, I would constantly think of food. I'd constantly be feeling hungry. And it was such a struggle. But you know what? I actually don't feel hungry anymore. It's strange. I have to remind myself to eat. So this is how, there's a much more kind of nuance to how these operations work. And we're still working that out. So that's the sleeve gastrectomy. And with this, you'd probably expect to lose about total body weight, 25%. So quite significant weight loss. And you sustain that long term, as long as you adhere to those eating habits that we've taught you. And then you've got the gastric bypass. So this is the kind of Rolls Royce of bariatric surgery. This has been there for quite a period of time. It's a little bit more complex to do. And so if this is your stomach, what we do is we make a little pouch and we exclude the rest of the stomach. But we need to connect this back up because we can't just leave it at that because you can't just eat into there. So what we do is we take a bit of bowel from here and we disconnect that, and then we take this up and plug this into here and join that together, and then we put this onto the side. So what you do is you eat into, and so we don't remove anything. Everything remains, unlike the sleeve where we remove part of the stomach. But what you do here is you eat into this little pouch, and then the food suddenly hits this bit of small bowel, and it's not used to hitting that bit of small bowel, because usually it goes through the stomach, through the duodenum, and into the proximal small bowel. But it hits the mid-small bowel. And again, we used to think, gosh, you're restricted in what you can eat and you've got malabsorption. But actually, you're producing a hormone called GLP-1. And some of you may have heard about these new injections in the market, so Wegovy, Saxenda. So this is a surgical way of producing this hormone. So you start secreting these hormones, GLP-1, which reduces your appetite, helps with your insulin sensitivity, controls those blood sugars, and just improves your general health. So these are the two common operations that we perform. Now, so we've talked about, we really need to look after, select our patients carefully, make sure that they're ready for this operation. But once we operate on them, it's not easy, it's hard work. So this is a tool for them to use, for them to they'll still have to be careful about their diet, their exercise. But the other aspect to this is we need to look after them nutritionally. So you're going to have to be on lifelong supplements. So they'll all take a multivitamin and mineral, they'll all take a calcium and a vitamin D supplement and an iron supplement, and 3 monthly B12 injections, and we have to check their bloods annually. So it's quite a bit of work, and they have to engage in that pathway, and it's really important that they've got that good support structure so that they get a good outcome. I think I'll probably a couple of other things that are probably novel. So we've talked about surgery. There are other novel things around, such as intragastric balloons, but they're temporary fixes. I've just touched a little bit on the hormone that's recently been released that works well. With these types of operations, we're losing about, 25–30% of total body weight. With these other interventions, maybe not as much, maybe 10 to 15%. I wonder whether I just stop there. Justin, I wonder whether we just stop there and then we can maybe just open it up to the floor and see whether you've got any questions and maybe we can have a chat about